So how I manage cardiogenic shock is something interesting. We have to admit that the proportion of shock patients among patients with acute myocardial infarction is still relatively stable over the years. And even if we look at the more recent data, even though reperfusion strategies becomes more and more active everywhere around the globe, you can see that the trends in the occurrence of a cardiac shock, if anything, are increasing and not decreasing. Interestingly, the mortality is decreasing both for the non-shock patient but also for the shock patients. And this is true here in France or UK, and it's also true in US here with 2 million patients here. And you can see, again, a decrease in mortality rates here occurring over time, even though the incidence seems to increase in these conditions. So it is really still an actual problem, not disappearing with the advances of therapies of cardiac patients. And obviously, we do better job now than we did before. And so it's important to really continue to practice in this way. The first aspect is recognition of the patient in cardiac shock. And of course, recognition of the cardiologic aspect is often relatively easy, but recognition of shock is again very difficult, and we have to base ourselves once again on the definition, recognizing that hypotension is not always the clue, and that the imbalance between oxygen supply and demand is very important. And again, and especially in cardiac shock, SVO2 is not enough to say that you are in shock, because SVO2 will decrease well below the patient is really in shock. And so, indeed, once again, using lactate as a trigger is a very important aspect. So, recognition of the patient in cardiac shock includes some clinical signs, and the measurements of lactate is one of these very important aspects there. So, as for other type of shock, we will use the windows of the brain altered mentation, even though sometimes it's more preserved in cardiac shock than in septic shock. The skin alterations that are often very prominent, the kidney alterations, of course, with the oliguria, which is important, but here, perhaps the most discriminant aspect in my mind to detect shock is the lactate levels that are very important in recognizing the shock aspect. And again, in cardiac shock, especially the increased lactate levels are often associated with tissue hypoxia as reflected by the elevated LP ratio. But even in cardiac shock, after a while, even when lactate levels remain elevated, you can see here in black, the LP ratio often becomes normal after 24 hours. So some other aspects than just the hypoxia is driving the lactate levels after some time. So probably most of our efforts to try to improve perfusion should be in the early stages when we have indeed a lot of things to do at that point. So I know that I guess that my patient is in shock. I need to rapidly identify the cause. And I need to do this and at the same time or rapidly after treat the cause, which is probably one of the very important aspects. And of course also at the same time I need to have supportive therapy. It's not very good to know that my patient had an acute myocardial infarction, that I need to do revascularization therapy. If I leave my patient hypotensive and in shock, maybe he will be dead before going to the PCI facility. So indeed, I need to do all these three things all together. I will somewhat dissect it for the purpose of the lecture, but at the bedside, I need to go for the three things at the same time. Looking for etiologies. If you open textbooks or here the guidelines, you can see that indeed we have a lot of different aspects that may lead to cardiogenic shock, including ischemic heart disease, but also infiltration of the myocardium, including metabolic derangements, including toxic, including tachyarrhythmias, and so on. If we go back to trials and we see what are the most important aspects, it's mostly the impairment in LV contractility, mostly due to the myocardial infarction. That is one of the most important contributors of the cardiogenic shock occurrence in our patient. Some mechanical aspects should not be neglected. And mitral regurgitation to papillary muscle aspect, ventricular septal rupture, right ventricular dysfunction, and other things can be there. So echo, once again, is crucial because even though in most cases we will figure out that there is some ischemic disease and that we need to go for some specific aspect, nevertheless, detection of some surgical abnormalities that needs to be rapidly corrected is a very important aspect. Diastolic dysfunction. We always discuss a lot the diastolic dysfunction. In respiratory failure, it is quite obvious. It is often implicated in the pulmonary edema. In shock states, it might be implicated. It's an important contributor, but it's not really the sole cause of shock in our patients. So we need to have something else. So if you don't see an alteration in the systolic function of the heart of your patient, you need to look cautiously for valvular disease and or for a communication between the left and the right side. So because often this may be missed by a rapid screening echo in your patient. Identification of the cause, again, will include rapidly the use of the coronary angiography. This is really the key in many cases because indeed this will have some therapies, it has to have some therapeutic implications, and it is important to revascularize as soon as possible our patients. We have, of course, also to check for vascular disease, as mentioned, and not only to detect it, but also to treat it whenever possible. And of course, rhythm rate control is also something very important because arrhythmias are contributing factors that should not be neglected. And in many cases now, we have patients who develop cardiac shock due to tachyarrhythmias that are prolonged, and that one of the factors that needs to be done in these patients is to control the rhythm of these patients. Revascularization, the best trial is indeed that trial, the shock trial that occurred close to 20 years ago, 15 years ago, the results were published. And indeed, at that time, the early revascularization was associated with a marked improvement in the outcome compared to the patient who had initial medical stabilization and later on were revascularized. This was really a major advance. It changed totally the way we practice with this patient. Before this, mortality was close to 70–80% in registries. With that, we have seen that mortality is now around 45–50% maximum. And this is really one of the key factors that can lead to the improvement of our patients. Also, the concept there behind it. We have something to treat, we need to treat it very rapidly. This means that it's true for the coronary angiography and the ischemic aspect. It's probably true also for the other factors that can contribute to the cardiac shock, including the valvular disease, including, of course, the arrhythmias, as we just discussed before. The most important aspect I will discuss now is the supportive therapy, because we will admit that we have done everything we should to treat the cause as soon as possible. And then we have, of course, to provide the supportive therapy. And one of the first things to discuss is basically diuretics. Why? Because if your patient crosses the door of the emergency department in cardiac shock with difficulties to breathe, perhaps one of the first things you will receive from our colleagues in the emergency department is some dose of diuretics. We have to admit that diuretics can be discussed and can be suggested in some cases perhaps, but only if our patient is really hypervolemic. This means that it is congestive heart failure evaluating to a point where indeed he enters into shock state. In most other cases, if you have a patient who was normal, developed acute myocardial infarction, this patient is not hypervolemic. This patient just before myocardial infarction was like you and me. So he just developed sudden cardiac attack. At that point, blood volume has not the time to increase. So this patient is not hypervolemic, and we have to be careful that in normal volemia, and in addition to hypovolemia, diuretics can be dangerous, because indeed, if we give diuretics at this stage in dilated cardiomyopathy, okay, preload will remain somewhat constant, and we have no impairment of stroke volume. However, if we give it in this stage, then we will decrease the preload, and we enter the risk to further decrease cardiac output, which is already at that stage compromised because it is a patient in cardiogenic shock. And so we need even, and this even in the guidelines of the ESC, when we have indeed inadequate perfusion and no obvious congestion, we need indeed in these patients consider the fluid challenge. And so we should consider the fluid challenge, and of course our patients have often less probability to respond to fluid, but we need to evaluate this. And whenever possible, we can apply the usual principle to try to predict the response of fluids. When it is not feasible, because the patient is not yet intubated and so on, and that's arrhythmias, then of course we should consider a cautious fluid challenge, once again, giving volume and evaluating the effect. The aim of the administration of fluids is not to let fluids enter the patient with no evaluation and to drown the patient. We need indeed to ensure that when we give fluids to this patient, the patient has a positive response to this. And of course, it depends where you are, but often echo guidance is very important in this condition. You do the echo, you give some fluids, and you check the response of the heart by doing the echo online with this. The second line of therapy is, of course, the application of positive pressure. And positive pressure has also some beneficial effects, but also potential detrimental effects. And the risk is, of course, a decrease in preload in some conditions, and the decrease in afterload is a beneficial effect. For the preload, once again, it's like for diuretics. If we have a congestive heart failure, it can be really beneficial. Often it is not the case, and we risk really to be facing here a patient with a normal volemia, and then applying positive pressure may decrease the preload. So we need, once again, to have first ensure that the preload is adequate by having given fluids if necessary to our patients. But the most important aspect is probably the impact on afterload. Remember that in spontaneous ventilation, if you need to have a blood pressure, let's say, of 80 for the brain or for the kidney, the hearts need to generate 80 millimeters of mercury. If we are in positive pressure, by applying a small positive pressure here, let's say, of 10, by definition, the heart needs only to generate 70 there. This is one thing, but remember that our patients are coming in shock, acidotic, they are dyspneic at that stage, and because they are dyspneic, often they are with a very negative pressure initially. So to generate these 80s, they need indeed to generate the 90. So in comparison to this, we offer, even with a minimal pressure, we offer quite a lot of, for the afterload, and there is a marked decrease in the afterload. So we should apply some positive pressure. In practice, CPAP can be enough. It really depends the severity of your patient. And so if your patient is hypercapnic, you might consider to have indeed the pressure support. And of course, you need to ensure the comfort of your patient. If your patient is really in major shock or needs a revascularization and cannot stand lying on the table, then you need to consider, of course, intubation and invasive mechanical ventilation. But again, be careful with the sedation and so on that can further decrease preload and vasodilate your patient. So the other therapies beyond reperfusion will be anthropic support, vasopressors, and mechanical support that we need to discuss. So the real question is, when we see this patient with such a heart which is almost not contracting, you may ask yourself, should I give or not some anthropic stimulation with this? And of course, the price to pay maybe is the increase in oxygen consumption in the myocardium. So you say, oh, I don't want to give it. The problem is really need to see what is exactly at the same time the outflow of the outflow of the patient. Here you can see that we have quite a marked decrease in the output at each systole of this patient. And given this, it's probably wise to give some anthropic stimulation. So again, the SVO2 and lactate may help to guide the indication, and then we have to select what would be the anthropic stimulation we would like to have. Dobutamine, levosimendan, milrinone, these are different possibilities. Of course, beta-adrenergic stimulation is probably the most frequent one. We stimulate the beta. We have the AMP cyclic that is activated. We have entry of calcium, and of course, we have muscular contraction. So we have several data showing that indeed there is an increase in contractile function, often with an increase in stroke volume in these conditions. The alternative will be, of course, to have the phosphodiesterase inhibition. In normal condition, the phosphodiesterase is indeed deleting the cyclic AMP into AMP, and so leading to the restoration of the calcium stores. By inhibiting it, we can prolong the action of the stimulation of the beta effect. And so it's often a joint effect that we may face in these conditions. So there are plenty evidence that indeed administration of enoximone here compared to the butamine may lead to a higher cardiac output, but also to a lower blood pressure because of peripheral dilation into these conditions. So the risk is really the dilations that we may face here with this kind of drugs, and we need to be also very cautious about the long half-life compared to the butamine, which is only a few minutes. The enoximone is a few hours. And so if we have no beneficial effect, but we face the side effect like the vasodilation or the arrhythmias, these may be prolonged. So in my practice, I prefer to begin with the butamine. If my patient do not respond to the butamine, then I may consider adding enoximone in this condition, but very cautiously initiating it, because if, once again, with a very limited dose, there is no effect, there is no reason, and there are already some detrimental effects, there is no reason to have higher doses that will have more profound effects. Levosimendan is, of course, the alternative, and in these conditions, it is not really this pathway which is activated, but sensitization to calcium, which is the alternative. And there are several reports showing that indeed levosimendan may be effective where some other drugs may not. However, if we look back at the most important data we have now, it's really always the same kind of data like this one. Here it was in acute heart failure. They were excluding shock, but there were nevertheless patients with hypertension that were included in this trial, and nevertheless no positive response. And recent data in cardiac surgery were exactly in the same line with negative results. So very difficult to say that we have better effect with levosimendan than with others. And so we consider this as an alternative, but the first drug is still the butamine. And you can see here that in observational trials, there is no difference between noradrenaline and dobutamine compared to noradrenaline and levosimendan in patients with septic shock, in cardiac shock. Vasopressors, norepinephrine is a drug of choice. We have several alternatives that can be considered, but nevertheless, when we compare dopamine and norepinephrine in patients with cardiac shock, we observed an increase in mortality in the patient receiving dopamine compared to a patient receiving norepinephrine, and perhaps the tachycardia and the arrhythmias were indeed the factors that were leading to and contributing to this increase in mortality, with much higher arrhythmic events with dopamine compared to norepinephrine. dobutamine, norepinephrine versus epinephrine, no major data up to now, but already this one is not very reassuring, with a similar blood pressure, more or less similar cardiac index, but a higher heart rate with epinephrine, higher lactate levels with epinephrine, higher pCO2 gap with epinephrine, and lower urine output with epinephrine. So obviously seems not to be the best alternative. And when we look also at the database, we can also see that in patients receiving epinephrine, it seems to be that the mortality is higher in these patients compared to the other one. Other alternatives seems not to be valuable, and inhibition of nitric oxide is not better than norepinephrine in these conditions. So guidelines indeed suggested that norepinephrine is the preferred agent in this condition. Mechanical support can be considered. Intra-aortic balloon, yes, we don't use it very much anymore, indeed, because of this trial, and this trial was negative, and so we may perhaps say that mortality was not so high in that trial, but nevertheless, we have to realize that in patients who are revascularized, which is the majority of our patients now, it was no effect of the use of the balloon in this patient in shock. What about ECMO? Well, the data are even more limited, of course. In some conditions, we may consider it, and we have data from observational cohorts that indeed it is associated with some survival in patients who are not expected to survive, which is basically the way we should look at the things. It is really rescue therapy, and indeed, we have to be acknowledging the potential indications, which are quite various, but also the severity of this patient, which is quite large when this patient receive it. Obviously, the survival is not so bad in these conditions. And it seems that the use is increasing over time, even though mortality is the same. We should not forget about some catastrophic events like the neurologic outcome, which can occur up to 16% of the cases in these conditions. So what recommendations say is that after initial stabilization, we should indeed consider the use of ECMO in these conditions. And this is indeed what we try to do. And how to identify the patient who may require ECMO. Once again, be careful. The hemodynamic pattern between survivors and non-survivors is not always that easy initially. And one of the things that should be considered is probably the coronary perfusion pressure, which is often much lower in patients who will not survive compared to patient who will survive. And with this, I thank you for your attention.